I've looked through the minutes of the last meeting. Thank you, Antje, for taking those. They were an accurate reflection of the meeting, so that's fine. We'll accept them. Mention of a couple of upcoming social events in the near future. Friday the 14th of November, there'll be an archives tour of the Medkai collection of books. Nottingham Medkai has a large collection of books which are held for us at the moment by the University of Nottingham at the Kings Meadow campus. And we manage about 12 people at a time can go and look at these, and it really is genuinely very interesting to go and do that. I did it earlier this year, and the offer's there again on Friday the 14th of November to go and see the books, see what we've got, see how they're cared for. So do sign up for that if you're a Medkai member and you're keen to do that. Saturday 22nd November, just in time for Christmas, there is a glass fusion workshop. This is your chance to come and make some personally made Christmas decorations. So that's here at the Postgrad Centre here at 10 o'clock on Saturday morning. On the horizon in terms of social events, not on the slides here, but if you remember in years past when things were a bit more competitive, we had a Medkai go-karting competition several times. I'm bringing it back, so there will be Medkai go-karting in March 2026. For those of you who are feeling a little bit competitive and want to get some teams together. And breaking news as well, we've booked a venue for a Medkai ball in May of next year. So that will be on the 16th of May, Saturday the 16th of May in the conference centre. So get that in your diaries and look out for more news about the Medkai ball next year. President's charity, as ever, is Doctors in Distress. You can go to the site to see the link there. I looked earlier today and we've given over £1,000 recently to Doctors in Distress, so thank you very much to those of you who've done that. And I understand that Ms. Leela Kapila recently gave a very big donation to that. So thank you very much to those of you who are doing that and supporting my chosen charity. They do a lot to help doctors who are in trouble for one reason or another. The next lecture, which is just in 3 weeks' time, Rachel Buckingham is a children's orthopaedic surgeon who works in Oxford most of the time, but uses quite a lot of her holiday time to go to Africa and floats around on the Mercy ships, treating children mainly from sub-Saharan Africa for life-changing operations, mainly for lower limb abnormalities that would have no chance of having surgery if it wasn't for her good work going and doing that. And she's coming to tell us about it in about 3 weeks' time. So please come along to that if you're able. Tonight, we've got Mr. Henry Marsh, who has come to give us a talk, Prima non nocere, or first do no harm. I'm delighted that he agreed to come along and talk to us tonight. Just by way of brief introduction, Henry was born in Oxford, where his father taught law. He studied at the Westminster School in London, and then he read politics, philosophy, and economics at Oxford. And he was saying to me earlier tonight, he didn't really go into medicine and become a doctor till he was 30, which would be unusual then, a bit more common now. He graduated with honours in medicine from the Royal Free Hospital and started out in a surgical career. And his own son was ill with a neurosurgical problem when he was very little, and that influenced Henry's choice of specialty following that, and he decided to go into neurosurgery. And he worked for many years as one of the main surgeons at St George's Hospital in London, where he pioneered the development of awake craniotomy techniques for low-grade glioma surgery, and really became very, very influential with that. Also well known for travelling to Ukraine to operate since 1992, and he's just been there a few days ago, so he's continued to have his links with Ukraine neurosurgery. He's well known as well through a number of TV documentary appearances, and he's written 3 best-selling memoirs, Do No Harm, Admissions, and then most recently, my favourite, Finally, Matters of Life and Death, which Wikipedia pithily described as being about death and neuroscience. It's about a bit more than that, I think. But if you had to summarise a book in 2 words. He was appointed a CBE in 2010, and in 2023 received medals from the Royal College of Surgeons and the Society of British Neurosurgeons for his massive contributions to British neurosurgery. I'm absolutely delighted that Mr. Henry Marsh has been able to come and join us tonight, so please give him a warm welcome.
Good evening. Thank you very much for inviting me to come and talk to you. One of the nice things about writing a bestseller is that what's happening? In trouble already. Oh yeah, is that you get fan mail. And I got a letter from Dr. Linda Hill, who's was director of the public health program at the University of Southern California in San Diego. And she wrote, this is about 10 years ago, when in America they introduced an 80-hour work limit for the residents. Personally, I think that's about the right amount. I think the EWTD is a disaster, but that's another story. And she said that when the committee, she was on the committee which was imposing this 80-hour working week on the residents, and the head of neurosurgery in San Diego came to the committee and said that neurosurgeons should be given an exemption. It was hopeless. You couldn't possibly train neurosurgeons on the basis of an 80-hour week. And when he was asked why, he said, well, because neurosurgeons are superior humans. Wait for it. Mentally, physically, and sexually. And she said, this is true. It's not making it up. And I must confess that when I became a neurosurgeon, I thought neurosurgery is all about heroic figures. And to some extent, that's true in the past. Cushing, Dandy, Lexell, Kearns, there's Spetzler recently at the Barrow, and there in the bottom, Henry Marsh, the future great neurosurgeon. So I can't, although I was influenced by my son's brain tumor, and he survived and is fine, we're very lucky. There was a lot of egotism and glory and everything else, as well as a fascination of neuroscience to make it a bit more respectable. But I was, without a doubt, I was attracted by the risk and the danger, and that really continued throughout my career. On the whole, the more dangerous an operation was, the more I wanted to do it. And of course, an important part of surgery is learning when not to operate, and you have to suppress your ego. So I thought it was heroic and dangerous. I didn't understand they were dangerous for myself and not just for my patients. Because of course, when patients are harmed, we suffer shame and guilt, although there's this sort of stereotypical view that the surgeon, particularly the neurosurgeon, is a sort of psychopath lacking empathy. It's not true. I mean, I know one or two surgeons who have slightly psychopathic elements to their personality, which mean they really didn't seem to be upset when patients came to harm. But that's pretty unusual, where the variety is how well we hide that distress and whether we act on it or not. And of course, you're worried about your reputation. And I published my first book before I retired. I didn't want to sort of light the blue touch paper and run away. But it's not a book I could have written at the beginning of my career, I don't think, because it's really mainly about failure. And then there's expense, litigation. But the real problem, looking back on this, is what the philosophers call moral harm. Because it's easy to deny our responsibility for a bad outcome, for which we've been at least in part responsible. And this is something I think we have to struggle with throughout our careers, the problem of honesty, of living, to use Václav Havel, the Czech politician, living with the truth. And we're diminished if we don't. And I think all of us, including myself, have suffered this to some extent. Now, we all know medicine's dangerous. And as I said, some of us are drawn to the more dangerous areas. But the fact of the matter is, until this report came out, the Tour is Human report from the American Institute of Healthcare 26 years ago, we as doctors all knew there were lots of mistakes and problems. But it was extraordinary how things were brushed under the carpet on the whole, and they were not acknowledged or admitted to, which made our lives as doctors easier. Perhaps it maintained confidence in the medical profession as well. But of course, it means you don't learn. And if you're not honest about mistakes, learning is greatly slowed down. And the statistics on iatrogenic damage are extraordinary. I mean, the 99 ones, between 50 and 100,000 avoidable deaths in the US. And a recent study in this country argued that 1 in 5 deaths in patients under the age of 75 were in principle avoidable. So it's a huge problem. Now, what lessons did I learn over the course of 45 years as a neurosurgeon? I really want to talk about, firstly, how to minimize mistakes and avoidable harm, and secondly, how to establish trust with patients so that if things go badly, as they invariably do from time to time, how we can reduce the risk of getting into trouble. These are lessons I learnt, but I still teach at St. George's, and it seems to me the medical world is changing profoundly, just as I have changed profoundly over the course of my career. Now, some of you may have read that book. It's really very good. He's the world ping pong champion. He was at one point, and is a sort of popular philosopher. And it's a book really about the way progress depends on failure and learning from failure. And he illustrates this partly with some of the iconic aeroplane crashes. There was a famous crash for Korean Airways many years ago. Jumbo jet coming into land on the island of Guam in the Pacific, very bad conditions. The ground radar was being serviced, so it wasn't working. And the pilot was having to more or less fly by the seat of his pants as to how high he was. And you can hear the black box tape recorder, the co-pilot saying 200 meters, 150 meters, 100 meters, 50 meters, and then they're all dead. I think one air stewardess survived. And there was another iconic crash slightly before that one. You've got to remember that actually flying was quite dangerous 30 or 40 years ago. And because of the development of aviation safety culture, it is incredibly safe now. It's actually the safest way of traveling per mile, amazingly enough. And in this crash, the light, which should light up when the undercarriage descends, failed to light up. And the pilot was struggling to try to work out whether the landing gear had come down or not, and going through all the manuals and everything else. And you can hear on the black box tape recorder his engineer, this is in the days when you still had an engineer in the cockpit, saying they're about to run out of fuel. And they ran out of fuel, the plane crashed. A lot of people were killed, although the pilot survived, and many years later committed suicide. So Syed in his book describes really similar accidents. And it's very interesting. What did Korean Airways conclude from their crash? Well, the co-pilots should speak up. In fact, if you read Malcolm Gladwell's book, I think it's on Tipping Point. There's some argument about Korean culture, hierarchy, not criticizing seniors, but also that senior pilots should listen. And although the relationship between, say, a consultant surgeon and his assistant is not quite the same as between co-pilots and senior pilots, there's still some truth in that, and I shall illustrate that later perhaps. And cabin crew training, and this of course is the beginning of aviation safety, is creating a no-blame culture. Now, I used to be very sniffy about saying, you know, aviation safety has a lot to teach us as doctors. I said, oh, operating is much more difficult than flying an aeroplane. And I still think that's true. It's a very different business. But there are still lessons to be learnt. And these are lessons which are spreading throughout the NHS slowly about the business of teamwork. And working in countries like Ukraine, where I just got back from 24 hours ago, it's fascinating to see a culture which still hasn't got this and is like we were 40 or 50 years ago. What did I conclude? Well, the highly skilled, highly trained pilots can make terrible mistakes and die as a result. And surgeons are no different. We make terrible mistakes. We've all made terrible mistakes because we're human beings. Now, the WHO checklist was introduced into St. George's, where I was moved from the wonderful old Atkinson Lawless Hospital in 2003. I was very opposed to it. I got all sniffy and complained about it. What is possibly wrong with it? Well, I think, and I remember saying to my niece, Judith Dinsmore, but I did not want somebody to tell me which side I'm operating on. And then she reminded me I had actually once operated the wrong side on craniotomy. Fortunately, the patient, I didn't actually enter the brain, and the patient came out of the theatre with a strange W-shaped occipital incision. And there was another case when I was taking a junior through a cervical foraminotomy. This is all before checklists. And straightforward operation, CT scan, MRI, looks pretty similar on both sides. But something was bugging me. My junior was doing the case plans in charge, and I was scrubbed up. And something was bugging me. I was walking down the hospital corridor later that day. I thought, we'd done the wrong side. We'd done the left foramen rather than the right. Now, it would have been very easy, actually, to have covered it up. A post-operative scan would not really have shown very much. Often the operation does, or sometimes the operation doesn't always work. So I could have said to the patient, well, we'll wait and see, but if you don't get better, we'll operate again. But being me, being an honest chap, I went up to him. I remember him very well. It was called Quine, which is the name of a famous logical positivist American philosopher. I said, Mr. Quine, I'm terribly sorry, I'm afraid I've got some bad news for you. And he looked at me and said, well, what's that, Mr. Marsh? And I said, well, I'm afraid we got an operation on the wrong side. And he said nothing and looked at me for a while. And then he said, well, that's all right, Mr. Marsh, I quite understand. I'll put you in fitted kitchens for a trade. I want to put one in completely the wrong way around. I understand. Just promised me you'd do the right side as soon as possible. So I was lucky. But nevertheless, despite this terrible past history of twice operating on the wrong side, I was all fussed about the WHO checklist, of course. And I think it's a jolly good idea on the whole, but why was I so opposed to it? Well, loss of autonomy and status. You know, I didn't like to think other people could tell me what I was doing. But actually, much more importantly, I didn't like to be reminded before going into the operating theatre that I might make mistakes. You know, you need this self-confidence, self-esteem. And I felt kind of threatened initially by that. I overcame it. I've also had problems with the WHO checklist. I think it's been implemented the wrong way. You need to involve the people who will use it to design it. It's a good example of the one-size-fits-all, top-down management in the NHS, which is causing so much harm. I was very impressed. I went to the MD Anderson, Texas, and in Houston, and saw there that they get the staff to design their own checklist, which is then reviewed by some bureaucratic committee. But at least the people who use the checklist, our stakeholders, are involved. Because obviously, a checklist is just a bit of paper. The question is the team who use it, whether it can be used properly or not. And if it's been imposed on them from above, it's less likely to be used meaningfully. But that sort of lesson has yet to percolate through to the poor old NHS. So I'd say to my former stupid self, Henry, when you're flying in an aeroplane, would you rather pilots use checklists or not? And of course, the answer is yes, I would. But there is a profound difference between surgeons and pilots. Our problem is we survive, the patient doesn't. But if the patient dies or is left trashed, as my American trainees used to call it, we have to cope with that. And then that causes serious problems. And the great French surgeon, René Louis, I wish I'd written this myself. Every surgeon carries within himself a small cemetery to which he must go from time to time to contemplate. A place full of bitterness and regret, a place where he must look for an explanation for his failures. And we all have an inner cemetery to a greater or lesser extent, and we don't like visiting it, but it's a very important part of being a surgeon, in fact, being any kind of doctor. That is actually the neurosurgical block at St. George's in the top right-hand corner with a conveniently placed cemetery just in front of it. So error in medicine, how does it arise? Well, carelessness, taking your eye off the ball, but the problem is we have to find a balance between being detached and not emotionally involved, and at the same time not losing our humanity. And although the word care in this context is ambiguous, carelessness in one sense is something we have to practice. If we care too much, we don't make the right decisions, we get too involved. And finding that balance between caring and, in a sense, not caring, between cold clinical detachment, I think, is one of the biggest difficulties, one of the most important aspects of being a doctor. It can be ignorance, I'll illustrate that in a moment, poor training, lack of study. I mean, it is extraordinary how with the internet now, everything is there at your fingertips. When I was a trainee and as a consultant, if I had an unusual problem, it meant going down to the library trying to find a journal. Half the time I couldn't be bothered because usually the journal wasn't there. And I was often in retrospect really quite ignorant, but now there's no excuse for that now. It's wonderful how you can look rare, unusual problems up so easily and so quickly. And although there are quite a lot of problems with AI diagnostics, which is a separate issue, it clearly has great potential to help us. And then there's a problem of cognitive biases and limitations in decision making. We are fallible human beings. We have what is called bounded rationality, and I shall talk a bit more about that in a moment. And then there's the Swiss cheese model, popularized by the English psychologist James Reason and his studies on error, mainly in engineering systems, but then applied to medicine. So Gandhi is a very good American writer, surgeon, I don't think he operates very much now, who states it very simply, the problem is not stopping bad doctors from making mistakes, but stopping good doctors from making mistakes. The problem is when we make mistakes, the consequences are so awful, they're so bad, does not necessarily mean to say we're bad doctors. We're human beings, but there's so much emotional baggage to the fact our mistakes come at such a high cost. Here's an example of ignorance. As a child, I operated upon years ago with Chiari, malformation, and nocere. The family really became quite close friends. They like me, I liked them. I had to operate more than once, but the boy was fine. And when I lost touch with him, he grew up. And then years later, the parents come back to see me waving the MRI scan. And it showed that, and I just looked at the foramen magnum, and I said, well, it looks all right, the syrinx is gone, you know, there's nothing more to be done. And I kind of glazed over that black, I don't know if this is working, there's all black stuff over the cerebellar foliae. And I thought nothing more about it. He was going deaf. There's an odd clinical picture which I couldn't attribute or explain and relate to the foramen magnum in any way. So I said, well, it's some strange neurological problem. He was actually becoming quite disabled, they told me. And then a couple of years later, or a year later, at Christmas, I got a letter from the mother. I thought it'd be a nice Christmas card. It wasn't. It was a very angry, bitter letter saying, we wish you'd noticed he had superficial hemosiderosis, which I'd never heard of before. It's a very, very rare complication. But as it so happens, when I mentioned this to my colleague Andrew Martin, who is very well informed and reads the journal Neurosurgery every week, every month, he said, oh yes, there was just a paper published this week, he said, Henry, about superficial hemosiderosis after surgery. There's a rare complication. It's untreatable, so even if I had noticed it, it wouldn't have made much difference. But the interesting thing about that was how hurt I felt, because I'd disappointed the family. And again, it's this business of a trusting relationship, how just as our patients trust us, we depend upon their trust, we sort of float, we fly on their trust. And when that's taken away, it is incredibly painful, even though, in a sense, fortunately, even if I'd appreciated that scan, I hadn't been ignorant, it wouldn't have made any difference. But the point is, we are not Dr. Spock, or Mr. Spock. No, Dr. Spock was a childcare specialist. We are not Mr. Spock. We have what Herbert Simon, the great Nobel Prize-winning guy, called bounded rationality. And this, of course, has been wonderfully illustrated by Danny Kahneman, who died a couple of years ago in his famous book, Thinking Fast and Slow. I'm sure some of you know it. He got the Nobel Prize for economics, although he's a psychologist. And he, with his late colleague Amos Tversky, showed how we have what are called cognitive biases. Now, the surgical decision, and in fact all medical decisions more or less are the same, are the chances of a good or bad result with treatment versus the chances of a good or bad result without treatment. But the point is, these aren't facts, these are probabilities. And because they're probabilities, you know from Kahneman's work, they're subject to all sorts of emotional distortions in what should be a rational assessment of what is best for the patient. I mean, in simple terms, on the left you have a fairly rare traditional neurosurgical emergency of an extradural, where the decision making is simple. If we don't operate, the patient will die. If we do operate quickly, the patient will probably survive without any brain damage because the hematoma is outside the brain. But the much more common situation, of course, is on the right, where you have an intracerebral hematoma. And then the decision making is quite different, because we think if we operate, probably the patient might be more likely to live, although there's no actually good trial evidence saying that. We know the patient will be left disabled to some extent. And the question is then, do you operate or not? The comorbidities, age, all sorts of factors come into it, just make decision making incredibly complicated. I noticed years ago, my trainees would ring me up at night. This is very simple surgery. You don't need to be a consultant to do it. And you get rung at night and the scan is sent to you on the internet. Usually if I said, go ahead and operate, I'd get back to sleep. If I said, let the patient die, don't operate, I wouldn't. But sometimes I'd go in myself, because I live near the hospital, and see the family. And of course, the trainee would have said to the family, you know, this is an emergency. If we don't operate, the person you love is going to die. If we do, they'll probably survive, but disabled. In effect, you're saying to the family, do you love this person enough to look after them when they're disabled? Which, of course, they'll fall, yes, of course. I would go in, easy when you have white hair and look a bit old and tired, and I'd say, look, you know, you to the family, you're the ones who know this person. Would they want to survive? And I mean, I try to give some idea of what the degree of disability would be like. These are very unpleasant conversations. They take a long time, often at 2 or 3 o'clock in the morning. And usually the answer is no, don't operate. But these are all probabilities, and they're subject to all sorts of very, very soft reasoning. Now, we know from, it's an analogy with the Muller-Lyer illusion, however hard you look at those two lines and say, look, it's different lengths. And we have similar, but not quite so hardwired problems in our thinking. I used to think the word cognitive meant something terribly complicated. All it means is just scientific word for thinking. And Kahneman showed with Tversky, they're using lots of experiments mainly on weird, white-educated, intelligent, whatever it is, students in American universities. In fact, a lot of these experiments have been repeated all over the world, all ethnicities, all classes. We have these built-in shortcuts we make when we have to estimate probabilities. And there are many of them. I shall only illustrate 1 or 2 as applied to surgical decision-making. The halo effect is if you like somebody for a particular ability, they're very good looking or speak very well or whatever, you will consistently overestimate their ability at doing other things which are not related to the quality for which you like them. And one of the problems we face as senior doctors, particularly in surgery perhaps, is you have to judge how much of an operation to give to your trainee. If you give nothing, if you're always there, standing at your trainee's shoulder, they don't learn. And then you're going to have a consultant at the end of the process who's then going to make all sorts of mistakes because they haven't been trained properly. At the same time, I would not want to go back to the system I was trained in, which was more or less to see one, do one, the next one's yours, Henry, drop in at the deep end. Totally brutal, bad for the patients, bad for me, but you learn very quickly. And in the long term, you end up being much more experienced. When I was a junior consultant, they wanted my trainees to like me, I liked them, and I can think of several patients who came to terrible harm because I misjudged at what point to join them in the operating theatre. And I think I got much better at it. After time, you get a sort of sixth sense. But what you have to overcome is that halo effect, that getting the probabilities wrong because you like somebody, and to become more detached. The availability heuristic is a rather long, complicated phrase. It simply means no surgeon's better than his last operation. If you're an obstetrician and your last breach went disastrously, you'll probably overestimate the risks of the next breach you see. If you're in private practice, you also have to struggle against the fact if you're going to make money from an operation, you probably will overestimate the risks of doing nothing and underestimate the risks of surgery. It doesn't even say you're wrong, but we have to estimate probabilities, and there are unconscious processes that distort our thinking, and we can never entirely escape these. I'll talk about that more in a moment. So that's the availability heuristic. The emotional consequences of a similar event in the past, for good or for bad, distort our estimation of probabilities. And then there's also called inattentional blindness. I can't show the video because it's copyrighted. You probably know this one. You show people a video of people passing a ball around. And then you say, count the number of goals the people in white t-shirts score. And in the middle of the video, a guy walks into the middle of the room in a gorilla suit and goes like that. 75% of people do not see the gorilla because they're concentrating so hard on looking at the people in white shirts. And it's similar when operating. You know, you get so fixed on one thing, like the poor pilot who got fixed on the undercarriage. And that's an example. Another Chiari malformation. I've done many of these by the time this disaster happened. This is about mistaking post-operative infections, where these unconscious optimism, biases, denial come into action. Straightforward Chiari, you know, it's a benign condition. You don't have to operate. There's no syrinx. But she had significant cough, impulse, headache, and problems like that. So the decision to recommend surgery was fairly straightforward. Operation went very well. I managed to spare the arachnoid, not something I do very often. To make it worse, my colleague next door was also doing a KRA decompression and getting into trouble, was swollen and a mess. So I really thought, when I went home. And she went home 2 days later, comes back a week later, very complicated clinical picture. But anyway, I got a CT scan, and this is an example of unintentional blindness. The cerebellum is squeezing out of the posterior fossa. There is black stuff around the brainstem. I've never seen that before. I've never seen it since. It's a post-ocular subdural empyema. I didn't see it for 24 hours. I was so puzzled and confused, like these pilots who ended up being killed. And I hesitated before I properly re-explored the wound. I hesitated about 24, 36 hours, and she was left absolutely wrecked as a result. So that's an example of the availability heuristic. I've never had a serious complication like this before, and some unintentional blindness. I just couldn't see it. How do you resolve that? Well, the answer is teamwork, and I'll come back to that. The fact of the matter is, if I'd shown that scan to a colleague who didn't have my cognitive biases, did not have my optimism bias, did not have my belief I was a jolly good surgeon, he said, Henry, look, for Christ's sake, it's a disaster. Take her back to theatre. But I didn't, and I should have done. So then there's the Swiss cheese model of error, popularized by James Reason. And that, as you all know, it is the idea that when disasters happen in medicine, it's not because of one big mistake, but a series of small mistakes, where if the defenses are lined up in the wrong way, you can end up with a disaster through a series of small errors. And that's an example. It's a very benign meningioma, falcine, with a lot of edema, a bit like James Kellerman's case, but James's case, the tumor was about a quarter of that size. But she was diabetic, she was Korean, didn't speak much English, presented with a frontal syndrome, confusion, and personality change. So I wrote to the GP, with these a lot of edema cases where you don't get a big decompression by taking the tumor out, so you can end up with quite a swollen brain, and you haven't created a lot of space for the brain to swell back into. It's not very evidence-based, but I usually started high-dose steroids a few days in advance, rather than just the day before surgery. So I wrote to the GP saying, please start her on dexamethasone, whatever it was, 4 milligrams QDS or something, but check her diabetes, because it's going to get out of control. She's then seen in the pre-assessment outpatient clinic, going to save beds and time. Patients are brought in immediately the night before surgery. They're seen as everything is dealt with on an outpatient basis. So I go in and see her that evening. I was being a nice surgeon. I always went in the night before surgery. I was a bit late that day, so it was after 10 o'clock. She was very sleepy, and I thought, well, not surprising. And she doesn't speak English. My anaesthetist said the same. So she's anesthetized, and she's in a crashing diabetic coma, acidotic crisis. So we have to abort the operation, and she died. So that's an example of a Swiss cheese. There was a series of small errors which all added up to a disaster for a completely curable benign tumor. And it turned out she didn't have a blood glucose check routinely by the nurses on admission. So you might say, oh, wicked, naughty nurses. So who's to blame? But if there's any lesson from the patient safety movement, for want of a better word, is that's the wrong question. You shouldn't say, is it the GP or me or my anaesthetist or the admitting nurses? The systems error approach, as popularized by James Reason, is that that's the wrong question. What you should ask is, what went wrong? I don't know why the nurses hadn't done it. Probably because there was an agency nurse. Probably they were run off their feet. Organizational reasons why this very minor mistake was made, which in effect led to her death. So as I said, the fundamental insight of patient safety is that medical error usually occurs because of bad systems, which don't allow for the fact we're all going to make mistakes, rather than bad individuals. But I'll come back to that because there is a problem with this. So we need what's called a just culture, not the same as a blame-free culture. A just culture is that gross negligence will still be sanctioned in some way. Now, here's an example of how I handled a problem badly. I tell the story, actually, it's a chapter in my first book, but it's interesting, it's only since retirement I can see more clearly. But I did handle it badly. Trainees, done quite a few disc operations. I told him to start, I've got to go to a management meeting funnily enough, about junior doctor working hours. So I turned up a bit late. He'd already done quite a few disc operations, he told me. He'd only just started working for me. And I was a bit unhappy about it. It was a painful story, because there was a young woman, severe sciatica. I'd seen her 6 months earlier. I said, you don't have to have an op. Most people get better on their own. And she opted not to have the op, but unusually she didn't get better. So I went into the anaesthetic room before I had to go to the management meeting, and she was in floods of tears. I said, don't worry, everything's going to be all right. You know, it's a simple, straightforward operation. And then a young, slim woman, L5S1 microdiscectomy is usually very simple and straightforward. But I was bothered by the way my trainee was using something called a Lexel bone nibblers. All right, I'll put a pair of gloves on and come and help you. As I approached the operating table, scrubbed up, he cuts out this long bit of spaghetti from the wounds. It's the L5 nerve root. What had happened is that he had mistaken he hadn't found the midline properly. He mistook for any spinal surgeons in the audience had mistaken the lateral aspect of the facet joint being medial, which is a mistake I made myself once. I didn't trash the root. And I was very upset, obviously. I mean, this is a life-changing, permanent foot drop is a life-changing injury. Can't run, can't walk on uneven ground, etc. So I spoke to her and the family. I said it was my fault, you know, because I was in charge. My trainee did it. My blame. I told them to sue. Oddly enough, they didn't, probably because she would have been consented for a foot drop, even though actually it's so unusual with an operation of that sort. But what I got wrong was, I just sort of shouted at the trainee and said, oh, you know, stormed out of the operating theatre. I should have sat down to him and said, what went wrong? And given him a little anatomy lesson about, you know, how not to make that mistake again. But again, my emotions got the better of me. Now that I'm a wise old man in retirement, whether I could put all these lessons in the use lot, I don't know. I'm not sure. A lot of these things I understand now. I see my life as being on a tightrope. And when you're on a tightrope, you don't want to look down too much. You'll lose your balance. And to a certain extent, if you're doing a lot of dangerous surgery, you have to wear blinkers. So I'd like to think if I somehow magically was younger and went back to operating, I'd be able to apply some of these painful lessons. I've been going to Ukraine for years, long complicated story, tied up with PPE at Oxford. I almost became a criminologist. I was at Maidan, I was very proud of that. Trained a lot of guys as a child with a cerebellar astrocytoma, when I was showing my colleagues how to use an operating microscope. All very gratifying. Next case I did in that hospital, complete disaster, medulloblastoma and post-operative hemorrhage, and she dies locked in. Unbelievably horrible. Only child of an only mother, of a single mother. And the operation went fine. The error I made was that there wasn't really any proper post-operative care. The other case had gone so well. I didn't want to sort of rock the boat and say, look, you know, what's the post-operative observations going to be like? In fact, she wasn't looked after properly. She didn't do proper analgesia. Blood pressure went up. She bled. And that was it. So again, actually, it was really my fault for not rocking the boat and really trying to work out what was going to happen after the operation. It's the old cliche, you know, you can do the operation, but it's the post-operative care which kills the patient. So that was an example of availability heuristic. The previous case had gone very well. Optimism bias, everything's going to be all right. And what's called groupthink. I didn't want to upset my colleagues and actually discover that the post-operative care was going to be absolutely awful. There wasn't even, I discovered, a neurosurgeon on call in the hospital that night. I hadn't realized that. Now, how can we reduce error in medicine? Well, by a very simple truth that we need to understand that other people are better at seeing my mistakes than I am. It's a bit bad for our self-respect and pride, but they don't have my cognitive biases. And I'm better at seeing their mistakes than they are. Now, team working, as I'll say in a moment, is not a magic wand that solves all problems. But there is this very, very fundamental truth. And as surgeons, maybe particularly neurosurgeons with big egos and big ambitions, this is a very important lesson to learn. And it really is enormously beholden on senior surgeons to try to explain this to all the eager young boys and girls who want to be big brain surgeons. Yeah, you don't have to tell all the patients always that things went wrong. You don't always have to tell the public. But you really must create in your juniors and your colleagues an atmosphere of openness and true teamwork. And of course, you're not going to have good colleagues if you're not a good colleague yourself. It's necessary, but not sufficient. And if you're lucky, you'll have good colleagues. And I think having good colleagues, and I've always, in recent years, had them at St. George's, it really is wonderful. And it's so good for your mental health as well, given that working in the NHS, I think now, is 100 times more difficult than it was 20 years ago. So avoid blame, be a good colleague if you can. And the other thing, a very nice book about Gillis. It comes to mind because of all the ghastly facial injuries, max fax injuries I saw a few days ago in Lviv. Gillis, who sort of created the whole field of teamwork and plastic surgery in the First World War, never do today what can wait until tomorrow. Sure, you need to recognize an emergency when you see one, but to think slowly, which again is, Kahneman's book, Thinking Fast and Slow. Teamwork for surgeons. Well, constructive criticism, helping each other rather than destroying each other. In Ukraine, it's all destructive. Meaningful M&M meetings, very difficult to achieve in my experience, and MDTs, they easily become incredibly boring. You think, why am I doing this? What is it achieving? So a big problem, but it needs to be done. Open discussion of errors, not hiding them, because, of course, we learn more from mistakes and failure than from success, going back to Syed's book. I found it on the internet. I think it's rather a nice model of the modern idea of leadership. The leader on the right is supporting the team, empowering the team, rather than the model I was trained in years ago, where consultants were never questioned. They were totally godlike, never asked each other for their advice or opinion, and occasionally criticized each other at clinico-pathological meetings afterwards. But there was no meaningful discussion of difficult cases. And just like we didn't have the internet, with this vast amount of knowledge and information we have now. So some things are hugely better compared to the past. And I think this also illustrates that the business of leadership, because teamwork depends upon good leadership without a doubt, and that's a difficult thing to achieve. And I think this demonstrates it very well. When top level guys look down, they see shit. When bottom level guys look up, they see only ourselves. And this is a problem for all human hierarchies. And there's a problem with teamwork, which is, of course, the surgical ego, which is a big thing for surgery and neurosurgeons. And you remember Walt Disney, the Seven Snow White and the Seven Dwarfs, and the jealous stepmother, and their mirror, mirror on the wall, who is the fairest of them all? And we're all a bit like that, particularly when we're younger consultants. We also notice actually somebody up the road is probably a bit better than we are, or more experienced. Yeah, we have to present ourselves to our poor patients and families as being as good as they desperately want to hope we are. It's the corruption of power. Patients put us on pedestals, and this is very bad for us. It's intolerable as a patient, and I speak as a patient myself, with a variety of conditions, including cancer. To think your doctor might not be very good is intolerable, and you have to believe in them. And of course, this can have a very corrupting effect. So, as the great historian Acton said, all power tends to corrupt, and absolute power corrupts absolutely. I think as doctors, we often fail to realize just how much power, short term, we have over our patients. But there are problems with team working, with the phenomenon of groupthink. The group can easily make decisions that the members of the group as individuals wouldn't necessarily make, and this can be a problem for MDTs. As I said, a good team practices constructive disagreement, not harmony, above all, and the role of leadership is to bring that to some kind of satisfactory conclusion. That's hemangioblastoma. I'm sorry all my examples are neurosurgical, but it's inevitable. These are masses of blood vessels. It's the only time in brain tumor surgery you don't do debulking. Normally when you're operating on tumor, you might try to devascularize it. You try to make it smaller, debulk it, collapse it away from the surrounding brain to minimize trauma to the brain. But hemangioblastoma is basically just one big blood vessel. And if you go into the tumor, probably the patient will leave in a coffin. It certainly happened in the past. So you have to do a very difficult, careful en-bloc resection, the difficulty being influenced by how many major blood vessels there are around it. And that patient was admitted when I was working part-time. I was still operating a bit and doing clinics, and was admitted under my colleague, who was fairly inexperienced. I'd done a few of these, and it was a challenging case. I've been happy to operate. But he didn't want to operate. He obviously was a bit frightened by it, not unreasonably. But the radiotherapist stepped in and said, we can irradiate it, which I thought was slightly odd. But I said, well, I think it's surgical, but I didn't insist. I didn't want my colleague to think he was being a bit of a wuss. And I thought, well, maybe the radiotherapists know what they're doing. Well, the answer was they didn't. And it was a disaster, and the patient was left eventually months later in a non-conscious state. And in retrospect, I should have been pushed and said, look, I can do it, but I didn't. So that's an example of groupthink, where I put the interests of the group ahead of what I felt was best for the patient. But again, it's a question of judgment. You know, sometimes what you think is best for the patient, you might be wrong. So that is why good discussion, constructive discussion, is so important. And it's still happening. This was just in the press a week ago, or 2 weeks ago, I think, of a cardiac surgeon in Newcastle. He's been causing mayhem, and now he's been retrained and sent back to a department. And she was doing her best, she was doing operations she wasn't experienced enough to do. And that all reflects on the relationships between the consultants. And when you read about most medical scandals, almost always you'll find the underlying cause is bad relationships between the consultants. Complaints and malpractice litigation, it's always said, and I'm sure it's true, it's usually due to poor communication. You have informed consent, but again, poor explanation, and the doctor not appearing to care or being in denial when things go badly is very important. And then this very thorny issue I'll talk about in a moment about the lack of apology. It's all very well having a duty of candor to apologise, but now NHS costs are going up and up and up. I mean, you can say it's not sustainable. It's not sustainable, but nothing's been done to change this. And as I was saying to Douglas earlier, you know, this slide. I mean, I spend more than twice as much on obstetric litigation in this country as you do in obstetric care. That means something has gone seriously wrong with healthcare in this country. I mean, I think that's an absolutely staggering fact. And that's recent figures. That's quite new. Appalling. Communication. Well, why is it so difficult? Well, I think there's a very simple reason, which is we don't get feedback from patients. I went through, as any neurosurgeon, I had endless, terrible, breaking bad news conversations with patients, and more often their families, patient being in coma. But they never tell you afterwards whether you do it well or not. You know, I think most of us think we're much better at talking to patients than we really are, because we get minimal feedback. My generation, we got no teaching on communication at all. I think the medical students do now, but I think there's a much greater need for it at a postgraduate level, probably, because as soon as you become a doctor, a sort of glass wall descends between you and patients. And it's so difficult to know how well you're talking or not. And, you know, it's such an important part of medical practice of all sorts. And then this problem, as I said, it's a system failure. We're all good doctors, really. We make mistakes, but we're human beings. But does that mean is nobody responsible? As patients, we do want to feel medical staff to feel they're actually a person responsible for us. It's what we all want above all when we're patients. So we feel the person we're seeing actually cares for us to some extent, even though, as I said, paradoxically, from the doctor's side of the meeting, you need to be a little bit careless, so to speak. That's detached as well. But to what extent should we be accountable when we do make mistakes? And you may have seen this. I know the family. The parents are both well-known journalists, which was bad news for the dreadful doctors at King's. Martha had a bicycle handle injury, ruptured the pancreas against the spinal column, somewhere in the West Country, was admitted to King's, the great best place for pediatric liver and pancreatic problems, over a bank holiday weekend. Complete unbelievable mismanagement. And if you read it, really, it just is incredible. But I said, looking at that brain scan of the postoperative subdural empyema, I can scarcely believe that. These things happen. So in that sense, and she died from overwhelming sepsis. She was hypotensive, had a rash, which the junior doctor on call thought was an antibiotic reaction, high fever, and she was just left on the ordinary ward. And the senior consultant said she should not be referred to the pediatric ICU. All the investigations afterwards showed there were lots of conflicts and clashes, and surgeons feel they lose control of patients when they go on the ICU, which is true. And both the parents have written very eloquently about this. And then they've now got Martha's Rule, which I hope will be more than just another bit of paper on the walls of NHS hospitals, saying that as patients and families, we're entitled to demand an ICU opinion if we think the person, our relative, is deteriorating from septic shock or something like that. The husband, the father, wrote a very long, pages and pages in the London Review of Books, describing the whole thing and awful. But he says at the end, you know, surely these people ought to be punished in some way. In fact, the senior doctor was found guilty of serious professional misconduct, but nothing was done about it. And that was that. And I feel very strongly naming and shaming is a bad idea, just as I think that sending doctors to prison, like Barbara Garver and the general surgeon who spent 2 years in Belmarsh, category A, over some failed missed appendicitis. But the mother, Meripy, told me they had these endless meetings with several meetings with the doctors and management kings, and they wouldn't apologize personally. They just said, we're very sorry it happened. And what that meant, because the parents blame, they think they trusted the doctors, and the doctors let them down. Okay, we all make mistakes. I've let patients down, as I've been at pains to tell you. But if you don't apologize, you're putting the whole burden on. Those parents will go to their graves feeling they failed their daughter and she died because they trusted the doctors. Even the fucking doctors had the courage to say, you know, we're sorry. They clearly failed. But they wouldn't say that. And Mary, the mother, said, I was literally shouting at them, say sorry. No, they wouldn't. We're all sorry it happened. Unbelievable. Unbelievable. And that's it. And that's a terrible burden to put on the parents. Where are we? So the lessons I learned, which I try to spread by lecturing from time to time, firstly, you've got to build a trusting relationship with patients, and the real challenge is to treat patients as your equals, which gets easier as you become more senior and more experienced. We all have to sort of wear white coats, metaphorically or not, when we're juniors and sort of pretend we're better than we really are. But, you know, they come to us for our specialist opinion and help. We're not special godlike figures. They may feel we are, but we're not. You've got to be a good colleague and hope to have good colleagues, which isn't always the case. And having bad colleagues is a huge problem, as we see from these departments which get outed in the newspapers. And then you have the problem of being profoundly self-critical. We mustn't trust ourselves as much as our patients trust us. I've got to think slowly and ask for help. There's so many patients I think of where I should have asked for help, although to be honest, I didn't have many people I could ask for help in the early years of my career as a consultant. That changed. And that's changed, I think, in many departments now. This collegiate team working is so much safer. And to use checklists designed by the staff, or use them, not by some top-down NHS authority. And again, this is advice we all know, to listen to patients, and especially to children. I was always, coming back to the Meripy Martha Mills case, you know, they said, look, she's ill, and they didn't listen to her. And now with block shunts, and I dealt with a lot of those, I'd always tell my trainees, disbelieve the parents at your peril. You know, they're not anxious, stupid. They know the child, you don't. Stop thinking you're so clever and you know best. And when things go badly, apologize. And it is very, very difficult, even if you're not worried about litigation and things like that. Because if we are sued, we're insured by the government or in private practice by the do or something, but it still is so hard to say sorry. And yet, if you can, the amazing thing is how you get forgiven so often. I mean, more often I found people said, well, you did your best. It's not caring, not apologising, which causes so many problems. And of course, the dear old GMC tell us everything. So, you know, it's very important to have an apology. But then they admit that somewhere they say, you know, to be meaningful, an apology must be genuine. But so not admitting there's a slight contrast in a mandatory apology dictated by the GMC, and you know, it's got to be genuine at the same time. So this I think sums up an awful lot of, I think, the rubbish the GMC produces. So that was the child coming back to the parasitic I operated on just before the pandemic, and you know, what an incredible privilege, you know, to save a child's life like that. I mean, it comes at a price. But I still think being a doctor is that's not suitable for everybody. But I still think it's one of the most wonderful things one can be. And we're incredibly lucky to be doctors, even though, as I said, it comes at a price. Thank you very much.
Henry's happy to take one or two questions if anyone wants to ask anything.
So, yeah. Oh, yeah, of course. Yeah. It was the last time I came to Nottingham, you invited me. Yes.
I thought I might tell the story the last time I came to Nottingham because it was quite funny, because we asked Peter Homer to chair a panel in which you were one of the speakers. And it was I spoke to Peter and he said, oh, I know Henry. I used to be his chief executive at St. George's. And I remember him introducing you in the panel and saying how welcome and nice to see you there. But he'd like to point out that in your wonderful book on page 178, the chief executive you complained about was not him. How are we getting on with management? Do you look back at NHS management and feel that they are doing a difficult job under difficult circumstances?
Well, I think it's extremely complicated. It's very easy to slag them all off and say we don't need management, we can do it best. Clearly doctors need to be managed. But I mean, we know that management has been introduced essentially as a substitute for investment. Sure, you could spend the entire national income on healthcare and the whole population still dies. So you have to decide somewhere, and all healthcare systems worldwide are in crisis because of a demographic transition, more and more old people, and more super expensive, unbelievably expensive medical technology. So it's a problem. But in the case of you go back to Margaret Thatcher, who unbelievably said, no, we'll make the NHS so good in management, nobody will want to go privately, which shows such a complete, total misunderstanding. So it's quite clear to me this country does not spend enough money on healthcare. How you solve that problem is obviously very difficult. You put taxes up, the politicians don't like that. Holland had an NHS type system, which then ran into trouble. They now have some kind of hybrid insurance system, which basically means more people have to pay more for insurance. But something needs to be done about it. Endless reform, which Wes Streeting's talking about, is of limited value, although I agree with the thrust, the emphasis should be on primary healthcare, not spending money on hospitals. But, you know, an awful lot of management you deal with, it's very second-rate, waffle, total waste of time.
Anna.
I was wondering, do you think there's a certain age at which surgeons should stop operating? Because independent of how well you age, you will physically and mentally decline. Obviously, some people earlier than others, but do you think people should operate, you know, on...
Well, it's obviously going to vary from person to person.
But I mean, do you think someone should operate after the age of 70?
No, in general terms, no, I think is the answer. You've got to cut it off somewhere. But it's there are some of the, I mean, like, the answer is yes, on the whole. Also, as well as to make room for the next generation to come up as well. I went when I was 65. And I think it's an important principle in life, whether it's a dinner party or life itself, to leave too early rather than too late. And the same for one's professional life. So in general terms, yes, I think 65 is still a reasonable time to have compulsory retirement, which is not compulsory now, of course. On the other hand, I think you also should have a system, as I practice informally, where some retired doctors come back and teach, and you don't totally lose all their experience abruptly. So I'm no longer licensed by the GNC, but I go into St George's under the radar. I don't see patients, and I still teach the trainees quite often, which I enjoy doing, and I think they enjoy it. And the emphasis is always about mistakes and discussion.
We've got a question online as well. Is that Rupa Patel? Yeah. Hi, Rupa. Can you hear us?
Yes, hi. Can you hear me? Can you hear me?
You might be. I know some microphones on there. Speak up, Rupa.
Can you hear me now?
Oh dear.
I'll read out the question.
Right.
Thank you, Antje.
Mr. Marsh, will you advise us how to facilitate and conduct a good and enthusiastic
Trying to create an atmosphere of no blame, and that means the senior people setting an example, basically. You can't expect people at the bottom of the hierarchy to be open about failure if the people at the top aren't. And I also feel very strongly at M&M meetings for surgery, the consultants present their own results. In many departments, you have the juniors doing it, which strikes me as a mistake, because they're inevitably going to edit and censor. They hesitate to criticize their boss. So consultants should present their own mistakes and failures.
Jim.
The concept of accountability is an interesting one. I mean, I have quite a lot of experience in patient safety and writing around serious incidents, dealing with sort of families. And there's no doubt over the last decade, there's been a move to people wanting to see accountability. And I think that's very frightening for doctors when they hear that phrase.
Yeah.
But I think we're fighting a losing battle to deny that's what people want. I think what doctors need is to understand what are the consequences of accountability and arguably be protected from those consequences. Because as you say, the idea that accountability leads to a jail sentence, for example, there is no way then we will be able to create a safe culture, because people will run away from that, run away from opening up to their mistakes. So what do you think, how should we handle that sort of, if you like, demand almost now from the public? Indeed, West Streeting uses that term on a regular basis of holding doctors to account. And I think we're all frightened by that concept.
I'm saying sorry if you can, helps a bit. I think it's if people apologise genuinely, I think it will stop a lot of problems. And with all the scandals that get into the media, it's almost always a covering up, isn't it? Both by the hospital management and by the doctors involved. So you need to somehow support doctors to be able to say sorry. How you do it, I don't know, to be honest. I think that's what needs to be done.
David's got a question. But
it also means patients and families need to accept what we do is dangerous, and we're not godlike figures.
Can I ask you as well, Henry, while the microphone gets to David, your first degree was in politics.
Yes.
Were you ever tempted to go into politics?
Never. No, I like using my hands.
Never.
I don't want to make things all the time and be useful. I couldn't face being a politician. But that's a big problem. And if decent people don't want to be politicians, that's why we have a load of crappy politicians. We have to blame ourselves.
I wanted to comment on what was said earlier, that there's an expectation in the public, there's zero risk interventions so often, and certainly childbirth, the public perception is, and perhaps the reason there's such a large bill, is that people can think you can get pregnant and have a zero risk pregnancy. And then when something goes wrong, their disbelief fuels their anxieties. And I think educating young people to say that having a baby is something you have to think, because when you go to the obstetrician or the midwife for the first time, they weren't involved in you deciding to get pregnant. You present them with the pregnancy, and then they have to deal with the consequences. So it's a public information problem as well as the legal problems.
You might remember some years ago when David Cameron was Prime Minister, the Institute of Child Health, that American paediatrician whose name escapes my head, did a review on the NHS. And Cameron made a speech saying, "We will have zero harm." And there was a headline in the Daily Mail, I think, saying zero harm. So I was interviewed, I was asked to write a piece about the NHS by the Mail on Sunday, which isn't quite as awful as the Daily Mail. So I agreed to write it, provided I had full editorial control. And so they couldn't edit it or anything. So that was fine. The problem was 2 nights before, the son of a friend of mine said his son was writing for the online magazine Politico and wanted to come and interview him. So I drunk a bit. And I said somewhere along the line, I said, David Cameron is a complete twat for saying that we'll have zero harm in the NHS, because it raises all these false expectations. And there was a photograph of Cameron outside Downing Street holding a copy of my book, Do No Harm, which apparently he thought was very good. So that on top of my article in the Mail on Sunday about what was to be done about house advocating for a hypothecated tax, there was Prime Minister's favourite surgeon calls him a twat. Given what happened with Brexit, I think I got there first.
Miss Casey, follow that.
I spoke with you just before the talk, and you know my role. So as coroners, so often, sadly, we do look at situations retrospectively where things have gone wrong, and our hope is that lessons are learned. In the course of our training, we're constantly told to keep families at the centre of the process. I know, having read your books, that you have managed to do that throughout your career. But I'm not sure that that is common before the tragedy happens. How do you manage, or have you managed to do that? And what advice would you give to doctors in terms of keeping families central to the process?
In theory, it's a bit easier now, because certainly neurosurgery consultants don't work the mad hours I did in the past. I mean, I was on call every third night. Now it's more like once every fortnight. So you have more time, you know. So in theory, you have more time to talk to families. I set up the paediatric neurosurgical department at Atkinson Orders, which is a famous head-only hospital in Wimbledon. My office was 30 seconds away from the children's ward. Because of my personal experiences and my son, who almost died from a choric plexus papilloma, I'd like to think I was pretty good at handling the parents. It wasn't to check up on the medical man, just to go there 2 or 3 times a day, just to say, I'm here, have a chat, I care for what's going on. And I kept a close eye on the medical management as well. When we were moved to St. George's 20 years later, it was, oh no, you can't have a separate paediatric ward and neurosurgical ward. You've got to be part of the sort of paediatric department, which was about a 20-minute walk away. And I did both adult work and paediatric work. So I said, I can't do it. So I stopped, although that really was, in many ways, been my raison d'etre. But I knew I wouldn't be able to provide that same degree of involved care. But that was partly because of my own personal history. But on the whole, paediatric neurosurgeons are nice guys. You don't go into paediatrics if you're not pretty sympathetic. On the whole, I think, But how you, is that something you can train and teach? I don't know, you have to try. Let's try. And I think in postgraduate training, there should be more emphasis on that, rather than front-loading it onto medical schools. But it hurts. The more you care for your patients, the more it hurts. And it's hard work, and that's the problem. I mean, I'm amazed to hear that now, last year, for the first year, there were more medical school places and applications. So I think there's an alienation and estrangement of the seniors is all now percolating down, lower down, which is very worrying. And if you then combine that with crude accountability, naming and shaming, you can have a totally terrorized profession who just begin to put the wall up.
Kath Halliday, she's a paediatric radiologist.
I'm Kath Halliday. I'm a paediatric radiologist. So one of the things that strikes me about resident doctors is how they are not prepared at all for the fact that they will make mistakes and that people will come to harm as a result of those mistakes. And I've seen many colleagues, many excellent colleagues, absolutely destroyed by the fact that they've made a mistake. I mean, that's particularly obvious in radiology because our mistakes are there in black and white for everybody to point out later on.
You can't bury them. You can bury patients, but not scan reports.
There it was. I've seen many people completely and utterly, lost to the profession, completely change the way they practice because they've made a mistake and somebody has suffered harm as a result. So what do you think that we need to do as a profession? One, to prepare people for that in this current climate where we're not meant to be doing any harm. And secondly, to support our colleagues through those times when that happens.
I mean, the answer is good leadership, is it not? The senior doctors have to put their arm around the chap who's made a mistake and say, look, these things happen. And then talk about his or her own mistakes, which we all have made. That, I think, is the most effective solution. It reflects on the leadership, on the senior doctors.
Thank you. Following on that question, you've made quite a few remarks over how, over your career, the practice has changed a lot in terms of how people have evolved and adapted to how things have been done in the surgical field. And you've also made a full comparison between how medicine and aviation worlds have a lot of similarities. Do you find that how medical school and medical education is very backward and not a lot has changed over many, many years? And actually, to almost answer the question previously, like pilots, for example, will go and fly on their own very, very early on in the career within the 10, maybe in 20 hours of the training from the beginning, whereas we are not actually allowed to practice and make those mistakes very much later on in a career.
Well, it's very difficult. I mean, I suppose you're talking in a sense about appraisal and practice, but it's very hard to, once you're a consultant, to meaningfully judge whether somebody can operate or not. So I didn't quite get the question.
Education is not.
Is it undergraduate or postgraduate?
Most undergraduate.
Well, I can't judge undergrad. I have really no contact with undergraduate education. I didn't want to teach medical students because I fear I'm a bit charismatic and I didn't want to encourage them to become neurosurgeons. Literally. I mean that quite seriously. I think neurosurgery is a sort of compulsion you have to have, and not the, as we said today before the meeting, the sort of, I've always wanted to be a brain surgeon since the age of 5 is not the sort of person you want. But it is, I think it's something you really need to do. It's something that bites you at some stage of your training. So I have no experience of undergraduate training.
That could be a good note on which to ask Mr. John Rosen to propose a vote of thanks, if that's all right.